What is going on, wonderful focus learners? Welcome back to Confused Neuron. Look, we all know pharmacology and pathology can be ridiculously hard to learn. It's just a mountain of dense information. But today, we're going to make it make perfect sense. We are diving into a high-octane whiteboard explainer on rheumatic diseases. We're going to break down the pathophysiology, the pharmacology, and the ultimate clinical algorithms together, step by step. Before we get in the zone, go ahead and smash that like button, click subscribe, and let's get this going.
So let me ask you a really high-stakes question right out of the gate. Think about this. What is the absolute most dangerous thing about a confused immune system? It's friendly fire. When your body can no longer tell the difference between self and non-self, it literally turns its heavy artillery on your own tissues. And in the case of rheumatic diseases, this confusion leads to irreversible joint destruction and, honestly, chronic agony for the patient.
And that friendly fire concept illustrates exactly why we are here. Welcome to Confused Neuron. We're going to cut through all that dense, boring pharmacological jargon you see in the textbooks, and we're doing it using dynamic whiteboard-style memory tricks, mnemonics, and structured logic. So, grab your mental dry erase markers right now, because we are going to write what we say and say what we write to make these concepts absolutely unforgettable.
Okay, here is our whiteboard game plan for today. We'll start with the enemy, which is the pathophysiology. Then, the arsenal of drug classifications, followed by battle tactics and mechanisms of action. Next up is friendly fire and side effects, and finally, the master plan treatment algorithm, plus a quick bonus round on acute gout. Section 1. The enemy, pathophysiology and symptoms. Let's clearly define our primary target here. Rheumatoid arthritis, or RA, is an autoimmune disorder where rogue white blood cells just get incredibly confused. It's like they look at the host's own synovium, that delicate lining of the joints, and incorrectly declare it as non-self. Once that case of mistaken identity happens, boom, they initiate a relentless, highly destructive inflammatory attack. And this kicks off what we call the inflammatory cascade. Imagine it like a massive cellular domino effect. First, the white blood cells attack the synovium. This activates the T lymphocytes, right? And they act like generals calling in the infantry, the monocytes and macrophages. These cells then dump massive amounts of pro-inflammatory cytokines, specifically TNF-alpha and IL-1, straight into the synovial cavity. Meanwhile, your B lymphocytes are over there churning out autoantibodies just to keep the fire burning. The end result of all this chaos? Progressive joint destruction, erosions, and severe, severe pain.
Section 2. The arsenal. Classification of rheumatoid drugs.
Listen, I want you to mentally draw this table on your whiteboard in bright, bold colors. Highlight it, underline it, whatever you got to do, because this is the entire foundation of rheumatic pharmacology. We've got NSAIDs like celecoxib and naproxen. These are purely for symptom relief. They help the pain, but they do zero to stop the actual disease. Then we have corticosteroids like prednisone for super rapid inflammatory suppression. After that, we bring out the heavy artillery, traditional DMARDs like Methotrexate, which literally slow the disease progression down. Next level up, the biologic DMARDs like etanercept that target highly specific immune pathways. And finally, our gout agents like colchicine. Now, you really need to understand the crucial distinction between traditional DMARDs and biologic DMARDs. Traditional DMARDs are essentially broad immunosuppressants. Biologics, on the other hand, are like genetic engineering marvels. They act like pharmacological sniper rifles. And here's an absolute high-yield mnemonic for you. When you see a drug ending in MAB, like rituximab, that stands for monoclonal antibody. But if you see it ending in CEPT, like etanercept, that tells you it's a receptor target. MAB for antibody, CEP for receptor. Boom! Medicine makes sense.
Section 3. Battle tactics, mechanisms of action.
Let's look closely at the traditional DMARDs first. Methotrexate is an absolute staple in the clinic. It works as a folic acid antagonist. By blocking folic acid, it inhibits purine synthesis, which effectively starves those rapidly dividing, overactive immune cells. Then we have leflunomide. This one goes after a specific enzyme called DHODH, which is totally necessary for pyrimidine synthesis. When you block that, the autoimmune lymphocytes just freeze. They undergo cell arrest. We are quite literally hitting the pause button on the autoimmune attack. As for the biologics, they function a bit differently, more like a highly specific lock and key. Remember those pro-inflammatory cytokines we talked about earlier, like TNF-alpha? Well, biologics bind directly to those cytokines or their receptors, totally neutralizing their biological activity. By blocking this interaction right at the cell surface, they just snip the communication lines of the inflammatory cascade.
Section 4, friendly fire, side effects and contraindications.
Okay, pause and pay attention, because this is absolutely critical. Imagine me circling this in bright red marker. Methotrexate and leflunomide are completely, strictly contraindicated in pregnancy. Why? Because they inhibit cell division and nucleic acid synthesis to stop immune cells, so naturally, they will severely harm a rapidly dividing, developing fetus. This is a massive, high-yield fact that you absolutely cannot forget.
Moving on to corticosteroids. There's a famous, kind of funny medical rhyme that goes, "When doctors don't know what to do, they give steroids to you." And honestly, why is that? Because they work like absolute magic to suppress inflammation. But, as we all know, pharmacological magic comes with a fairly hefty price tag.
Let's do a rapid-fire rundown of steroid side effects. Long-term use causes a classic Cushing-like syndrome. Puffy face, fat redistribution. It causes osteoporosis because it literally suppresses calcium absorption in the gut. It spikes your blood sugar, leading to hyperglycemia, it can cause cataracts in your eyes, and it significantly increases your appetite. So yep, they are incredibly powerful bridge therapies, but you really do not want your patient on these long-term if you can avoid it. Here is another massive red flag. Let's conceptually draw a huge red X right across the board here. Never mix a TNF-alpha inhibitor with a non-TNF biologic. Just don't do it. Why? Because you will suppress the immune system so profoundly that you open the door completely wide to severe, life-threatening, opportunistic infections. We're talking tuberculosis and sepsis. Pick a biologic lane and stay in it.
Section 5, the master plan. Pharmacotherapeutic treatment algorithm.
Let's walk through this logical, step-by-step whiteboard algorithm. Step 1, hit it hard and hit it early. Start traditional DMARDs, usually methotrexate, as soon as possible after diagnosis to delay the actual disease progression. Step 2, since DMARDs take weeks, sometimes months, to fully kick in, you have to bridge the gap with NSAIDs or corticosteroids to give the patient immediate symptom relief. Step 3, if methotrexate monotherapy fails, you don't just give up. You combine traditional DMARDs or you escalate to the big guns, the biologics. So remember, hit it early, bridge the pain, escalate when necessary.
Section 6, bonus round, acute gout management.
Okay, quick pivot. During an acute gout flare, neutrophils rush in to phagocytize these sharp uric acid crystals, releasing hydrolytic enzymes that cause just explosive inflammation. So, how do we stop it? We deploy colchicine. It binds to tubulin, causing depolymerization. This basically paralyzes the neutrophils so they literally cannot migrate into the joint. It is a brilliant mechanism. But be warned, the side effect profile is notorious. You're going to see serious GI distress. Think nausea, vomiting, and let's just say a lot of trips to the bathroom.
And that brings us to the end of our explainer. Before we sign off, I want to leave you with a provocative thought that cements everything we've mapped out today. If you were the general on this cellular battlefield, and you had to choose between merely treating the symptoms with an NSAID or stopping the joint destruction entirely with a DMARD, which weapon would you draw first? Understanding that vital distinction is the absolute key to mastering rheumatic pharmacology. Thanks for learning with Confused Neuron today, and I'll see you in the next explainer. Keep studying hard!